So again, you guys realize he is like postponing the answer. Okay, Peter, he's tried everything.
No, I'm not treating a finding, I'm treating a patient.
And you're right. And that's a very good point. So in all fairness, that's true. So the patient has tried every single type of compression. They even use pump therapy. Okay. They work as in the post office, and they're at risk for losing their job because their leg hurts them so much as the day progresses. So before you answer the question, Rob, am I painting a picture here that is like, like you're in the shower and the steam is on the windows and you don't know what's going on? Or is this like, am I giving you're muted? Go ahead.
I'll be honest with you, Steve. I don't see a lot of those patients. It's somebody with deep venous reflux, common femoral vein, popliteal vein. They've more, 80-90% of the time, they've got a central venous obstruction somewhere. Yeah. Doesn't need to be completely occlusive. So to see isolated deep venous reflux, that's a little rare for me. And again, I don't want to steal anybody's thunder, but we don't have any options for that. At least none that I think that are reproducible and worth subjecting a patient to risk for now just for leg swelling.
Hi, I'm Dr. Steve Elias, and welcome to the veinPODCAST. Respect the elders, embrace the new, and encourage the improbable and impractical without bias. Welcome, everybody, to another veinPODCAST sponsored by Radcliffe Vascular. And today we're going to talk about a topic that we've kind of been avoiding in the vein world, and maybe it's because we just don't have all that much to offer for these patients. But really, we're going to call this the final endovenous frontier, infrainguinal deep disease. And we're going to talk about infrainguinal deep disease from many aspects. Both reflux disease, thrombotic disease, obstructive disease, and talk a little bit about what we think we can do now. And more importantly, what I want to get from our panel is what do we perhaps need in the future? Our panel today is Kush Desai. He's an interventional radiologist from Chicago. I tried to have two interventional radiologists, two vascular surgeons on here. Brian D. Robertis, who's from UCLA. He is a vascular surgeon. And then we have Peter Glavitsky, also a vascular surgeon from Mayo Clinic. And rounding it out is another interventional radiologist, Rob Lookstein from Mount Sinai Hospital in New York. So we have a nice balance. Everybody here treats deep disease all over the place, not just in the infrainguinal disease. And I kind of want to start out a little bit. Brian, let me start out with you. So do you salivate when you see a patient that has some post-thrombotic infrainguinal disease and like the iliacs are pretty good and the saphenous has been taken care of and they got a swollen leg and they have an ulcer? Is this the kind of patient like you just can't wait to treat?
Funny you should ask that, because when you asked me to be on this podcast, I started salivating until I saw the topic of infrainguinal. And I thought, oh, geez. No, I certainly, I think these are the difficult patients for us to treat without question. And you already sort of hit on the first thoughts that I have every time I see one of these patients. I think about their iliacs. I think about their superficial venous reflux. And I make sure that those have been assessed properly, because you don't want to be fixating on someone with infrainguinal occlusive venous occlusive disease and not appreciate that they have some iliac venous deep iliac venous disease that you could treat to actually make them much better. So you do want to do some imaging, I think, in these patients to look at all of these other areas that we know we have good results for treatment. Once you do that, then I think the next step that you didn't mention is looking for perforators, feeding the venous ulcer. And I think that's sort of bridging that deep and superficial venous system. I think those are the other things to think about. But beyond that, I don't think right now we have a lot to offer for these patients with infrainguinal occlusive disease. I wouldn't say we have nothing to offer, but we don't have any great solutions.
Right, and we're going to get into that. So Peter, let me give you another scenario. You have a patient who has a really swollen leg, and unilateral, and iliacs are fine. They've never had a DVT before. Somebody decided to ablate a saphenous vein that's about 5 millimeters in diameter and had a few little varicosities. And the patient comes to you and says, I still have a swollen leg, and all you find is reflux, common femoral vein, and popliteal vein reflux. Is this the kind of patient you just can't wait to treat?
Well, we see patients because nobody wants to see it. So where do they come? They come to the Mayo Clinic.
Right.
The fact is that you really want to define the cause of the swelling. If the patient's primary problem is swelling, it's unilateral, you want to be sure it's not a lymphedema. And that is very important. Then, as Brian says, you want to exclude any proximal venous obstruction. And if it really looks like it is a venous problem, then you want to have a complete picture of the venous anatomy and function. So I want to know, what's the deep venous situation, and you mentioned that this patient may have nothing else but deep vein valve incompetence.
No, Peter, I didn't mention this patient may just have it. I said this is all the patient has. You spent the beginning here avoiding the answer. So my question to you is, this patient has nothing else wrong with them. Let's assume somebody with half a brain, like one of us on this panel, figured out there's nothing else wrong, and all they got is deep venous reflux from common femoral, and popliteal. What?
Okay, so then what are the patient's clinical symptoms, and what kind of conservative treatment has she received?
So again, you guys realize he is like postponing the answer. Okay, Peter, he's tried everything.
No, I'm not treating a finding, I'm treating a patient. And
you're right. And that's a very good point. So in all fairness, that's true. So the patient has tried every single type of compression. They even use pump therapy. Okay. They work as in the post office, and they're at risk for losing their job because their leg hurts them so much as the day progresses. So before you answer the question, Rob, am I painting a picture here that is like, like you're in the shower and the steam is on the windows and you don't know what's going on? Or is this like, am I giving you're muted? Go ahead.
I'll be honest with you, Steve. I don't see a lot of those patients. Somebody with deep venous reflux, common femoral vein, popliteal vein, they've more, 80, 90% of the time, they've got a central venous obstruction somewhere. Yeah. Doesn't need to be completely occlusive. So to see isolated deep venous reflux, that's a little rare for me. And again, I don't want to steal anybody's thunder, but we don't have any options for that. At least none that I think that are reproducible and worth subjecting a patient to risk for now just for leg swelling. So that's a very rare clinical presentation, at least in my practice.
Absolutely. I mean, this is a rare situation,
right? And
especially if it's a congenital valvular agenesis. I've seen maybe 2 patients or 3 with this, So what I'm saying is that if that's the only problem, number one, I really want to exclude. I might even order a lymphoscintigram if it looks clinically that it's a lymphedema. But if it doesn't, and let's say the lymphoscintigram is negative, you can have patients with primary or congenital deep vein valve incompetence. Then you want to know, does this patient have valves at all that's repairable, and go from there.
Okay, so I was going to save this part to a little bit later on, but we're into it right now. So I agree with you guys that is a rare situation. So my next question is, and I've asked Kush since he didn't say anything yet. My next question is, why then are there a fair number of companies, and I'll give you my history about, working on deep venous valves in a little bit, but why are there so many companies then that are developing technologies or techniques to treat deep venous insufficiency if all of us tend to agree this is a very rare development? I mean, Kush, give me an idea. What do you think? Rob says he hardly sees these people. Peter says it's a very rare event. And I agree with both of them. Why then, Kush, because you have some sense about industry, why are we pushing to either percutaneous valve placement or open valve placement?
Well, so, it's a great question. And everything we've done so far addresses obstruction. But we know that we're missing the reflux part of it. And reflux and obstruction are what contribute to ambulatory venous hypertension. So placing a stent in an iliac system or in a common femoral down to the profunda treats the obstruction, but we really got nothing for the reflux. And, as I'm sure all of us tell our post-thrombotic patients, I'm going to get you better. I'm not going to get you all the way better. And so maybe there's this glimmer of hope that putting in a valve or doing an open valve repair might push them along further. But to your point, a lot of these companies are looking at, we're looking for patients to start our initial studies with primary congenital valvular insufficiency. I said, good luck. You'll power it by the year 3000. That's not going to happen. You need to be pragmatic and you need to start looking at challenging patients right up front, because otherwise, if you want to answer the question, you need to start with real world patients, not with the ideal patients to meet some nebulous performance goal.
Yeah, and I agree, and all of us are excited by this. Many of us have dealt with this for quite a long time. I mean, honestly, I'll just give it very brief. That's where I got into the vein world. I was lucky enough to be with a doctor up in Buffalo, Sid Tahari, that Peter knows, vascular surgeon, did one of the world's first vein valve transplants, axillary vein with a good valve, transplanting it. Thinking back though, and I was a first-year resident, and if it wasn't for him, I would not be talking to you guys now about vein disease, because he got me into vein disease, and that's where I always knew I wanted to wind up. But thinking back on it, we probably didn't realize the great majority of those patients were really post-thrombotics that really had obstructive symptoms more than reflux symptoms. So Peter, let me bring you back. I'm going to say you're younger than me, but not by that much, or maybe a little older than me, but not by that much, but we're around the same time. So I am
younger than you.
Right, that's true. So my question is, Peter, were we wasting our time in the past talking about valve repair, talking about valve transplant, when we really should have been spending our time doing what most of us do now, taking care of the obstructive aspect?
Well, we did not waste our time. And when I said that it's a rare problem, valvular agenesis, congenital valvular agenesis is rare. But when we look at non-thrombotic lower extremity reflux, that's actually quite frequent. Even in the SEPS trial that we did on the perforating veins, when we did, as you remember, endoscopic perforator ligations, there were more non-thrombotic than thrombotic patients who had incompetence. So when you talk about overall chronic venous insufficiency due to infrainguinal disease, I think there are quite a few patients who have a deep vein primary valvular incompetence, the type of incompetent valve that Bob Kistner and Saturai and others and us repaired, you know?
Right.
So what I am saying is that even though obviously we all see more post-thrombotic patients, but there is a pretty large group of patients who have advanced chronic venous insufficiency and never had documented deep vein thrombosis.
Yeah. No, I
add to that. I think Kush really hit the nail on the head when he talked about the fact that these patients don't get all the way better. I don't disagree with Rob that it's very unusual for us to see patients who have massive symptoms, significant swelling, and isolated deep venous reflux. But That's only because those patients that we see with that also tend to have some degree of iliac vein compression in the left side. They have some degree of superficial reflux. And so we have things to do for those other areas, and we do those. But if you take your average vein patient with multiple complaints, albeit some of them are not very specific, maybe they're a little bit on the vague side, a little swelling, a little aching, pain, et cetera. These patients never respond like an arterial patient with claudication. SFA stenosis, you had the atherectomizer stent that, they get 100% better the next day. And that's not a phenomenon we see in our venous patients. And that's probably because of that residual deep system reflux that we haven't addressed. That's why they get 50% better, 75% better, manageable, but not 100% better.
Yeah, and I think the other thing about venous disease versus arterial disease is that all of the other veins, aside from the one that you either fixed or got rid of the obstruction, distally, they've been stretched for so many years, intramuscularly stretched, just all over the place. And it's like, I tell patients, it's like blowing up a balloon. You blow up a balloon once or twice, you let out the air, it goes back to its normal size. You blow up a balloon 100 times, it's never going back to that size. So we have we have multiple things. You've been stretching this for so long, you relieve the obstruction, you still have reflux. Those veins are just not getting back to where they were. And that's why with venous disease, it's not like you said, Brian, that we could say to somebody, we're going to take care of your arterial blockage. Tomorrow, you're going to feel a big difference. So that's our challenge, to figure out what we can fix, what we can't fix, and setting the expectations. Now I'm going to go a little bit more into your guys' comfort zone a little bit. We're going to move away from it. Okay. Rob, why do we say in general, someone has infrainguinal acute venous thrombosis, that all you do is anticoagulate? Why is that basically what we're saying at this point?
I think we have no evidence that supports that a aggressive approach, whether it's endovascular or surgical, changes the outcomes in terms of the patient's functional status of their limb or their quality of life. We've never been able to prove definitively that a open femoral popliteal segment impacts a patient 6 months later, 2 years later, 3 years later. We believe it does because we're all, vascular specialists and we like to do procedures, but we've never been able to prove it. And so still to this day, whether it's in the US, whether it's in Europe, all the randomized trials can't seem to identify a specific population that will improve with a more aggressive approach. And as a default, I think all of us on this call still are comfortable managing as first-line therapy, therapeutic anticoagulation for isolated femoral popliteal DVT.
So do you feel then, Rob, that we should not even pursue the idea of removing thrombus from infrainguinal veins?
Acute or chronic?
Acute. First of all, there is no such thing as a chronic thrombus.
So I would say that we have a half a dozen FDA-approved widgets that do it incredibly well. And I would say that we all use them typically in the setting of concomitant iliofemoral clot to make sure that, most commonly in a patent popliteal vein has enough outflow to get up to the inferior vena cava. I, for one, am humbled by the amount of work that has gone into design trials by people I'll say are much more thoughtful than I am about this, and still have not been able to come up with a signal on which patients, which clinical presentations, which anatomic subsets will clearly be benefited by an endovascular first approach. The other thing on the other side of it is that I think all of us in our practice find that most patients, at least 80%, feel radically better after they've gotten a week of therapeutic anticoagulation. And so it's so rare. And again, I'll be very humble. I think it's unpredictable still as to which patients will fail therapeutic anticoagulation and present to your office at the 1 week follow-up or the 2 week follow-up and say, I just still don't feel better. I can't ambulate. The swelling is really debilitating. I can't resume my normal functional existence. It's rare. And I can't call them a priori. I don't have that insight to be able to sort of, sniff them out on the front end.
No, I agree.
Steve,
go ahead.
One, just to be completely clear, I agree with Rob, but I want to be crystal clear that infrainguinal includes the common femoral vein.
Yes.
Fem-pop segment to me reads as caudal to the profunda. So caudal to the profunda, I would agree, and the thoughtful, much smarter people that have designed the trials have clearly shown that those patients really just don't get bad PTS. There's going to be a lot of people that disagree with us, but I think that the data from an RCT that was rigorous proves that that's probably the case. But the common femoral vein, I think there's equipoise. If there's common femoral vein involvement and it's not really going above the inguinal ligament, then you look at the patient. And I think all of us would agree that we've seen patients that don't have iliac extension of clot, have it focally into the common femoral vein above the profunda, and you look at their legs, and those are not the same patients as fem-pop segment patients. Those patients have more swelling. You can try the anticoagulation, maybe have them come back for a closer follow-up within the first week, and you may find that some portion of them are actually not getting better at that same slope as the typical fem-pop patient.
So Kush, I agree with you 100%. My semantics, I'm calling fem-pop infracommon femoral, like exactly. Femoral vein and popliteal vein. Common femoral vein and above, I discuss endovascular therapy. I really think that is a patient where there's a much greater likelihood that they're going to fail anticoagulation. Maybe it's 30%, 40%. It is not 15, 20% like you see in the femoral vein. So I agree with you 100%.
So can I follow up with that real quick and just I think Kush to some degree took away from a little bit of the point I want to make, but I want to ask Rob, since you mentioned we can't identify those patients that won't do well or will have residual severe symptoms with disease isolated below the common femoral. What would you say about like a 22-year-old ultra marathon runner that runs in the mountains 50 miles in a day and comes in with a significantly swollen calf after 3 days of anticoagulation for isolated femoral vein DVT? Do you think that patient falls into these trials, and what would you discuss with that patient if not some mention of endovascular therapy?
Yeah, so the only thing that I'll share with you anecdotally is that I believe, and I can't prove this, that a completely 100% occluded popliteal vein is a different animal than a 100% occluded femoral vein. And I think that the natural history of that is slightly different. And in my humble experience, I think that the patients that come in with 100% occluded popliteal vein, they're the most symptomatic. They have a difficult time really feeling that they're responding well to optimal medical management. And I do bridge a little bit of equipoise with them, okay? Partially thrombosed popliteal, I think they do very well. Isolated, complete thrombosis of the femoral vein, I think they do very well. And honestly, I wait with those two, anatomic subsets for them to fail medical management.
So let me ask you, when, and I agree with you, Brian. I mean, that's my thinking here. What if we had a technology? Okay, remember, I'm starting this sentence out with what if. What if we had a technology that would 100% remove all thrombus from common femoral to posterior tibial and had zero complications? Would you guys say, we don't need it because anticoagulation is good enough? Peter.
Of course we need it. We would need it. Anticoagulation is not perfect, but that's the best we have. So, to think that, patients with infrainguinal DVT with anticoagulation all will become normal, I mean, that's just, it's not happening. So sure, if you have the, the magic device that removes the clot, I am sure that, of course, you need a study, but a comparative study, but I am sure that that will be better than heparin and anticoagulation alone.
Yeah. So you guys understand where I'm heading. I mean, I usually kind of start from, let's say, not say we can or can't do this. What if we can do this? Should we consider doing this? So Rob, you were starting to speak when I asked Peter the question. So answer this question seriously.
Yeah.
Don't be put off by the practicalities. If in fact we had a technology that could remove thrombus, common femoral, popliteal, and tibial without any complication at all, would you say, I'm not using it, I'm just going to put the patient on anticoagulation?
No, I would, again, just to entertain your hypothesis, I would fully support exploring that technology in a prospective trial, ideally randomized, to prove its worth. I'm, again, just to be candid, I don't believe a technology without complications exists.
No, it doesn't.
I think we're all experts here, and we've all seen our colleagues and our friends show us cases unofficially at meetings when we used to meet face to face, and we're just all like, "Oh my God, what did you do here?" For something that we all on this panel could use with our eyes closed. We've used these tools 1,000 times, 5,000 times, and you still hear stories of somebody doing something where you can't understand how a patient got hurt. So again, if there's no complications, that's great. I love studying those kinds of technologies. I'm the skeptic one, because I think if you put something out there, something bad's going to happen, and you have to prove its worth with prospective evidence.
No, I'm bringing a pie in the sky. I'm not saying that's reality, but my point is, I don't like to dismiss something based on the thought, oh, that's never going to happen. I would rather entertain, yeah, it might happen, and can we make it happen kind of idea.
The reason I would entertain it really is because of the patient that Rob brought up, which is the completely occluded popliteal vein. I mean, I got nothing for that patient. I can balloon them. I mean, I've tried paclitaxel balloons. None of it works. It doesn't stay open. And I'm just sitting there saying, like, I'm sorry. I mean, there's really nothing we can do here. And I completely agree with Rob and Brian and Peter, where we said, like, well, the femoral vein, who cares? Because what happens is if you have a good popliteal vein, you guys have all seen these venograms, you get that jog to a profunda collateral and it reconnects at the lesser trochanter. And those patients are effectively asymptomatic, but that pop. So if your theoretical device could completely clean the pop up, then I think for that reason alone, I'd be fascinated.
Yeah, and again, I'm putting it out there because I do agree with you with the popliteal, and in fact, when we started, instead of putting the axillary valve transplant up in the femoral vein, we went down to the popliteal because, as we all have said, it's the gatekeeper of the lower leg, whether it's obstructive or reflux. So I want to get a little practical here. What if one wants to lyse or treat some chronic disease in the femoral popliteal segment, and you're going to access, say, the tibial? Brian, what is the biggest size French that you'll put in either a PT or an AT if you're going to do some work in the femoral popliteal segment?
Well, I don't know that I put bigger than a 6 French sheath in a PT vein. I'm not sure why you would have to, depending on which devices you would use. But I think that putting a sheath that is too big for a tibial vein is less of a problem than the advantage you have of clearing that popliteal segment that we're talking about or other parts. So I'm not too concerned with access size there, but I can't say I've done larger than a 5 or 6 French sheath in a tibial vein.
Yeah. Rob?
I agree 100%. We're usually using access at the ankle just to facilitate, flossing in some way for a very complex reconstruction. And so, if your mainstay of therapy is going to be ballooning, you shouldn't need bigger than a 6 French sheath. I've gotten comfortable using these slender radial sheets at the ankle just because it's a slightly smaller crossing profile, and you can get 6 French balloons through and balloon up to 8 or even 9 millimeters in the popliteal. But I have not found a need to go larger than that yet.
Steve, are you referring to high tibial access? Because I think
Yeah.
we need to be clear.
Yes.
High tibial, not at the ankle, right?
High tibial, I've done 8, but I'm talking ankle. So you can open up the really have running room to open up the pop and get at least one calf vein open to drain the foot, drain the calf adequately.
Yeah, no, what I wanted people to take away who's going to listen to this is, and I've used 8s also in the high tibial as well. And I don't think it's, there's 5 other tibial veins there, 2 perineals, 2 anterior tibial, another posterior tibial. So I think you can go up to 8. I wouldn't do anything higher than 8. Let's talk about popliteal. What's the biggest push? We've had this discussion before, using the clot-triever or something like that. What's the biggest that you're going to put in the popliteal?
Boy, so I'll tell you that I'm going to go back to your tibial comment. And I just last week, the day before Thanksgiving, I put in a 12 French in the tibial. And I did cat 12 through it. No problem.
Ankle or high tibial?
High tibial.
Okay. All right.
A 12. Okay.
A 12. Yeah. And, it's so dilated that when I pull it out and after I put the purse string down, it still was dilated and filled with clot. Right. So in these acutely thrombosed tibials where there really isn't a whole lot of flow, and as you point out, you got 6 of them, take one out. And then you don't have to worry about the nerve. You can clear the pop, and you don't have to worry about trashing the pop because of your access. And to your second question, the more recent question about, accessing the pop, I worry about big access in the pop because that is the gatekeeper of the lower leg. So I'd much rather take out and be somewhat radical with a high tibial than with a pop, personally.
Yeah, I think those are good thoughts. Okay, let's move to really the biggest bugaboo, because now we've already decided that, okay, acute thrombus, anticoagulation, not a bad option. Infrainguinal, people do fairly well. If we had the ideal device, we might consider doing it. Let's talk about the real problem that we all see more often in day to day, which is, post-thrombotic chronic changes in the femoral popliteal common femoral segment, whether that's the only problem or whether that's the beginning of a problem with extension into the iliacs, and we're concerned with inflow into whatever we're going to do, common femoral up. So let's talk about, Brian, what are the things you might do if you felt you had a compromised inflow into a segment of iliac that you're going to stent down to the common femoral just above your profunda, but you don't have good inflow. Do you do anything to try and improve that inflow before you place a stent above?
The way you phrase that, quite honestly, no, I don't do too much to improve that. And the reason I say that is because our inflow, if you have a profunda vein that's open, as long as you keep that stent in the common, but above the confluence of the femoral vein and profunda vein, you generally have good inflow. I think our inflow in general is better through the profunda than we can visualize and document. So I don't worry as much about that femoral vein inflow. I think I'm getting most of my inflow from the profunda. But I do think it's important to make sure that you brought your iliac stents down as far to that confluence as you need to have good, to have your common femoral not be the source of your inflow limitation.
So, yeah, no, I understand what you're saying, and I agree. If you have a good profunda inflow, but there are patients that also have scarred profunda as well, and you don't have good inflow into those. And Peter, I'm going to ask you about the open options in a second, but Rob, what would you not place a stent above something like that, or would you try to do something to improve inflow?
So I'll tell you about a case I did maybe 6 weeks ago. somebody who came in with probably the most awkward venous ulcers I've ever seen, from his popliteal fossa down to his ankles, circumferential around his whole leg, palpable pedal pulses, ABIs are 1, and on duplex, every single thing below the common femoral vein, including the common femoral vein, is out. His iliacs, the lower external iliac at the inguinal ligament, was also completely occluded. Common iliac was open, cross-filling from the other side, all right? And so I tried to access a tibial vein, couldn't get through the pop. I tried to access at the ankle, couldn't get through the pop. Ended up perforating in the thigh multiple times. Ended up getting jugular access. Ended up sticking the saphenous, which was open, was able to dig through 4 centimeters worth of dense scar tissue in the common femoral, flossed that out, got a second wire into the profunda through another 4 centimeters of scar tissue, did kissing balloons to open up the saphenous as the outflow from the calf and the deep femoral vein. This is where I wish that Peter was there to do an open endovenectomy, okay? And just kept on doing larger and larger and larger balloons, ended up with a 10 millimeter balloon into the deep femoral vein and an 8 millimeter balloon in a kissing configuration in the saphenous. And 6 weeks later, all of his ulcers have granulated over. He's still getting wound care, but he's dramatically improved, and his venous hypertension claudication symptoms have radically improved also. And I've done that case maybe twice in my entire career, but that's the lengths that I will go when I see that there's no inflow whatsoever.
Yeah.
All right. But ideally, this patient should get an open repair. And I did stent down right above the confluence of the saphenous and the deep femoral vein.
So let's talk a little bit. That's great. I mean, that's a tour de force for sure. Peter, but let's talk about, Rob brought it up, I brought it up. Are open options still an option for gaining inflow or improving outflow for the leg?
Well, I would say it's not a frequent option, especially, I have worked so many years with Haraldur Bjarnason, and he would just stent everything, and he would be very aggressive, and he would even go to the origin of the profunda if that has to be done. But we had patients, and we started to do the endoflebectomy with iliac vein stenting first. And there are clearly cases where even if you put your stent all the way down to the common femora, you don't get a good inflow. And with open surgery and endoflebectomy, you can actually open up more flow from maybe the femoral vein, maybe from the saphenous vein, and the profunda too. So these are the patients where we did endoflebectomy, put a vein or bovine patch, and then put the stent still all the way down to the very distal common femoral vein, but we had a better inflow. I think it is a good operation. It has problems because it is still a thrombogenic surface.
Yeah.
And Dr. had a little bit better results than us with an AV fistula, and Wittens in Holland used fistula, but the fistula there is not without complications.
Right, so, but maybe in your hands it's a relatively simple, straightforward operation, but in general, there's a lot of scarring in that area, is a lot of issues that can occur when you're doing your dissection and stuff. So I don't think an endoflebectomy is like for every vascular surgeon in the world to do. I mean, don't you think it's a kind of a tough procedure?
It's not only that it's difficult, but also the minute you dissect the femoral vein and you want to put a stent in it, your vein is going to break, because the stent, especially if you dilate it, but the stent exerts a considerable pressure on this very flimsy vein, and we had to repair several times this dissected vein, because stenting a dissected vein is not the same as stenting a vein without surgical dissection.
Yeah, I would also point out that I don't think it's a simple procedure, and I think Dr. Levitsky is forgetting that he's an actual bona fide magician, and that is probably why this is doing a doable procedure for your average mere mortal surgeon.
No, it's not. It's a very, very tough. I mean, even when we were trying to just get a segment of vein to put an axillary valve into it, it's tough.
But just let me tell you the real value of endophlebectomy, that I did a few in drug addicts who had a very segmental stricture of the femoral vein, where they inject the drug in the femoral vein. And that is an excellent operation, for instance.
You have a very isolated segment. You don't have
very isolated portion.
Okay. So I want to bring you guys, we have a couple of more minutes and then we're going to close up. I want to bring you to to think of, Rob, you already brought up that patient with an ulcer, to think of the concept of improving outflow from the femoral popliteal segment just long enough to get an ulcer to heal. Because as you all know, it's easier to keep something healed than to try to get it to heal. It's the arterial concept. You do some angioplasty, whatever, for a gangrenous toe. It works long enough for the amputation site to heal. If it goes down, you don't like to go down, but at least you have a stable situation then. So I've taken the approach, and I want to know what you guys think, a la Mark Garcia's Access PTS trial, to utilize angioplasty plus or minus some type of thrombolysis in the femoral popliteal segment, just to stretch those disease veins long enough and to stretch them enough to decrease the venous hypertension so that someone may heal an ulcer. And perhaps the longevity may not be years, but if it's a couple of months and it's a percutaneous procedure, is there a reason we shouldn't try this, even though we know results of, venous angioplasty alone is not the greatest thing in the world? But should we take the concept that we're doing this so that we're just going to heal an ulcer, and then after that, it's gravy if it still is working? Kush, do you understand what I'm talking about?
Yeah, no. So, what I guess my decision-making would be this. First, I would exclude pelvic disease. If there's pelvic disease, we're going to treat it. Again,
for this podcast, we're assuming everything else is taken care of. And
gotcha.
We're also assuming that what we're talking about with femoral popliteal is the last thing any of us are going to attack in a patient with venous disease. So let's assume all that's been done. You still have an ulcer, and this is what you're left with.
Yeah. So if an ulcer has failed, the bed being foamed, and it continues to be present, to growing, getting worse, then I think, frankly, you have nothing to lose at that point. So I think there's value in trying that. But I personally would not take the approach of treating the fem-pop segment before the ulcer and all that has been treated, because I think that's not quite the right message.
Right. No, I'm agreeing. What I'm saying is this is all you have left.
Then you have nothing to lose.
Brian, you have any tips or tricks about angioplasty plus or minus thrombolysis?
The Access PTS trial notwithstanding, I have not found thrombolysis to be helpful in these patients beyond any acute period. But I do agree that there's little downside to angioplasty of the femoral popliteal segment. There's also, I think, little downside to stenting these, which is, of course, a very controversial thing. We all assume and to some degree know that stents don't work in the femoral vein. But I will tell you, I've stented about a dozen femoral veins, and about half of those have stayed open, and they've stayed open long term, like literally multiple years later, they're still open. So that's honestly surprised me. In the ones that have occluded, they've generally been patients with antiphospholipid antibody syndrome or some other aggressive hematologic issue. So I don't think there's a downside to angioplasty. I haven't seen a particular benefit to lytics in people with true chronic occlusions. And I would say that, along that idea of there not being a lot of harm in doing it, I think if you have a segment that you plasty it, you can't get flow through it, you cannot get continuous flow through it, leaving a stent in something that would otherwise just go on to occlude doesn't pose a lot of downside to me either, and that I would hedge on saying that simply because a year of anticoagulation, sometimes these things open up on their own as well. So I'm not saying there's no downside to putting in stents, but I've been surprised at the patency of stents in the femoral vein, which in my hands has been around 50%, which is not terrible, despite the fact that it's not great.
You bring up a very interesting discussion because it's been kind of a no-no. In almost everybody universally do not stent the femoral vein. Rob, what do you think of that? Should we do more of this and see what happens?
So I've done that also, and I will echo Brian's sentiment. Half of them stay open, half of them don't. The common situation, the most common situation is that everything is a total cord from the femoral vein confluence down to the pop, and maybe the pop is partially scarred down, and you're trying to do whatever you can. So if you aggressively angioplasty that and you have one area where there's a calcified valve or something and it's recoiling right there on the table, I think, sure, of course, the concept is almost like a tack. You just want something focal to just open that one little area. And again, I've done that. I think that works fine. That's not common. Right. What's unfortunately more common is you balloon the entire femoral vein. It's 40 centimeters worth of angioplasty, and you can't keep it open at all. And then to put 40 centimeters worth of metal in someone's femoral vein, that's very hard to palate. And I think that our conventional wisdom of don't do that falls into that category. We don't want to open up the floodgates and tell people cross every femoral vein fibrotic case and put full metal jacket, because nobody here thinks that's ever going to work ever. Yeah. The one thing that I've become a little bit more bullish about is somebody with a post-thrombotic calf in the setting of a completely occluded popliteal vein. And again, the common femoral veins open, the deep femoral veins open, the iliacs are wide open, but they're really miserable and they're having a hard time maybe managing an intermittent ulcer. Maybe they're diabetic. I've gotten a little bit more, if I can cross this popliteal and angioplast it, to your previous question, keep it open for 6 months, stabilize that patient, even if it goes down 6 months later, that's a win for that patient because they're able to live 6 months much more stable, possibly heal a wound. And so I'm doing that, not that it's a huge part of my practice, but I've probably done a half dozen in the last 12 to 18 months. And I would say more universally, the patients are improved as a result of that intervention.
Yes, and I agree.
Angioplasty.
Yeah, and I agree. And I've become much more aggressive too. We have a huge wound center at Englewood, and I think these are the people that you really do push the envelope on. And I think what people should take away from this is that a lot of us here are pushing the envelope. And as Kush said, there's not all that much downside, and there can be an upside on these people. And if your goal is not, 5-year patency, but your goal is healing an ulcer, that's a whole different story. So lastly, Peter, and everybody, we get to it. Peter, what is it that we really, really need in the femoral popliteal segment to make patients better? Give me one technology. I don't care if you think it's never going to work. If you could design it, what do you think?
I give you 2 technologies.
2, not just one. Okay, what do you got?
As you know, I am editing with Peter Lorenz, the Journal of Vascular Surgery, Venous and Lymphatic Disorders. And we have 2 great papers, or let's say promising papers in the pipeline that's relevant to our discussion. The one is the first ever human trial using the novel bioprosthetic venovalve in patients with chronic venous insufficiency. This is a Californian company, and the trial was done in Bogota, Colombia by Dr. Ulva. First 10 patients. It was presented at the American Venous Forum meeting. So keep your eyes open for that. It's already on PubMed and indexed and viewable. The other one comes from Australia, just accepted today. So I am free to tell you that it's in press. It is also, it was presented at the American Venous Forum meeting. It is on an endovascular procedure of endovenous valve formation.
Yeah.
And you know, this technique, this is the first 14 patients. And again, both of these are promising early results of a technique that appears to be safe with minimal thrombotic complication.
Right.
So this is the new stuff.
Right, but these are both for reflux. And right, and just full disclosure, I've actually put in a couple of those valves that Jorge has done in Colombia in the jugular vein of pigs before he started doing it in man, and I think it's a nice procedure. But as we said, that's the rarer event. Talk to me a little bit more about push. Talk to me, and we're going to finish up here. Talk to me more about the post-thrombotic people that have what we've been talking about, the changes. What is it? What would be nice if we had something?
What would be nice is something that can treat the common femoral vein without having to extend a stent below the inguinal ligament, subjected to the mechanical stresses that we all talk about, which the manufacturers are now talking about, now that we're on to our fourth on-label venous stent in the United States, with several more coming. Something that we could use that doesn't require a high degree of specialization and expertise that Dr. Glowitsky has and Dr. Komoroda have to do endophlebectomy, that could treat it, and then we're done with it, and then laying the stent within the non-mechanical portion of the pelvic veins, the iliac veins, that's no problem. That, I mean, if you want me to ask for my Christmas list, that's that device.
Ryan, what do you want?
I'm going to say the thing we need, we already have, and that's the art of medicine. And I hate to slam Rob's reliance on data and promote things that are not data driven, but I do think that we trials like Cavent and Attract and others, I think they've made it so that we feel very dogmatic about what we should and shouldn't do. And I would just like sort of remind all of us that there's so much we do in medicine that is not at all supported by data. And then we come out with a randomized trial about one specific thing, and we then feel like we have to adhere to the results of that very specific randomized trial with all of its enrollment issues and biases and things like that. And so I think that my biggest thing I struggle with is that post-thrombotic 24-year-old who's very active, who I see only 6 months after they've been on anticoagulation, and no interventionalist has talked to that patient about other options to consider. Not that we would do those things, not that I would lyse every 20-something-year-old with a femoral vein DVT, but I would probably anticoagulate them for 4 days and then check in with them and try to get to them in that couple of week window to lyse them so that they don't show up 3 months or 6 months later. Because once you're honestly at 6 months later with severe PTS, I can't even imagine what options would work well for those patients going forward.
Yep. Okay, so I kind of agree with you, but you use the word lyse them. As Rob pointed out in the beginning of this, we have a lot of new technologies that don't require thrombolytics to remove thrombus, and that may be the kind of person you want to use it on, somebody that you can quickly get out of fresh thrombus and efficiently. So, Rob, your wish, what do we need? Aside from people like Brian.
I'll go to something that we don't have. I would, to the previous conversation and Brian's, experience using, I'm going to use the term scaffolds for the femoral vein and or popliteal vein. I think it would be fascinating to explore the concept of a bioresorbable scaffold. And I know Brian's working on a technology for the below knee arterial circulation, but to try and, capitalize on that for the femoral popliteal venous circulation. So something that's able to keep a recalcitrant vein open for 6 months, resorb, so you're not leaving permanent metal in the patient, but just enough, to our previous comment, that you can heal the wound alleviate some of the PTS, get the patient stabilized, get them into stockings that are working, give them some functionality, and then let it go away. I think that would be an intriguing technology. It might not be as big a market as chronic limb-threatening ischemia, but I certainly think that the more that we are entertaining these infrainguinal interventions, we're going to need something. And a permanent implant, I think, just doesn't really sit well with any of us.
Yeah, and I think that's great. I think that's a great way. I mean, that's kind of where my mind is going. I think we need to, if I had to do something, I wasn't even thinking of placing some bioabsorbable. I was thinking of kind of more like a good device that does a real good endophlebectomy from inside, that basically just, reams out all the stuff. And then if you could treat the vein that you just, reamed out with some medication so it doesn't thrombose, that would be great. But I think, and my intent of this discussion with all of you guys, who was fantastic ideas and fantastic discussion, was that we need to realize the infrainguinal femoral popliteal segment is important, that we just can't ignore it and say, we're going to do nothing, forget about it. And the concepts of stenting, the concept of plasty, the concept of early thrombus, I think it's all going to hopefully sort itself out. I think we need to be more aggressive. As Kush says, if we do it pretty right, we're not going to make the patient that much worse. We may make them better. And we take the concept, we're not looking for perfection, but enough improvement for enough time so the patient can heal an ulcer, say, or whatever. We're not doing this for varicose veins. We're doing this for end-stage disease. So, I mean, I think it was really a great discussion, and it brought out the theme of this podcast and the theme of what I think everyone should approach medicine and maybe life with, which is, respect the elders, embrace the new, and encourage the improbable and impractical without bias. And that's the way I think we need to think about this, and certainly this infrainguinal issue that most of us have just given up and said, oh, there's nothing we can really do on it. So thank you guys a lot for this. This was really very enlightening to me also, and we look forward to seeing where this is going to go. All right, so thank you all.
For the invitation. Thank you.
We hope you enjoyed today's Vein podcast in association with Radcliffe Vascular. We aim to bring you important topics from the vein world, either topics that we ourselves feel are important or you, our listeners, feel are important. So review us on your favorite podcast app or send your thoughts, comments, and questions to podcast@radcliffe.group.com. That's podcast@radcliffe-group.com. You can also register to access newsletters, videos, and peer-reviewed journal articles. Thank you. Glad you listened. This is Dr. Steve Elias, and we'll see you on the next Vein podcast.